Welcome to the PsychopharmaStahlogy Show, a special NEI podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another episode of the PsychopharmaStahlogy Show, the podcast featuring the one and only Dr. Stephen Stahl. And today we are continuing our series of underutilized psychiatric drugs, and there's no one better to discuss this than our friend Dr. Jonathan Meyer. Jonathan, how are you?
I'm fine, Andy. I'm glad you're utilizing me for this podcast, too.
Yeah, absolutely. Well, you and Steve wrote the handbook on Clozapine, amongst others, so you are in some ways the king of the underutilized drugs because of your lithium handbook that we did a podcast on already. So let's just jump right in here. Clozapine, everybody knows, is sort of the gold standard. It's the most effective antipsychotic we have.
Shockingly so. And the point being is for most people with schizophrenia who have positive symptoms, the problem underlying positive symptoms is too much presynaptic dopamine release in a certain part of the striatum. If you're a rat, it's a mesolimbic pathway. If you're a human, it's the associative striatum.
Right.
But people with resistant schizophrenia do not have that excessive dopamine synthesis and turnover presynaptically. And surprisingly, that's why D2 receptor modulation does not get them any mileage. Clozapine makes some of these people better. And what we've come to appreciate is that these people have a glutamate problem, which likely comes from the anterior cingulate cortex. And Clozapine normalizes that in those people who are responders to Clozapine.
Do we know how it does that? The age-old question, how the heck does Clozapine work? Or is it more we know what it does, but we don't know how it does it?
Yeah, I think it has so many mechanisms. We're not entirely clear. I mean, I'll defer to Dr. Stahl. Do you think we really know how it works, or is it like lithium? It's 10 drugs in one.
Yeah, not at all. Do we not? We don't know how it works. We know how it doesn't work. It doesn't work by substantially blocking D2 receptors. But how it does work is by a yet mysterious mechanism. If we knew, there would be drug companies all over the place targeting that to try to make a new Clozapine, maybe with less side effects. But it's vaguely related to glutamate. As you know, there's the NMDA glutamate hypofunction hypothesis, in which the idea is that a synapse utilizing glutamate is sick during probably neurodevelopment. It's probably a GABAergic interneuron in the cortex, and it doesn't work right. And so perhaps it's restoring that. That would be obviously that's where the problem is, and that's probably where the solution is. But we don't know that yet.
That the whole is greater than the sum of the parts, that it is this multimodal thing.
Yeah, one thing I can add is that we know glutamate's probably part of the story. When you add things which are glycine transporter type 1 reuptake inhibitors, they can make other antipsychotics better because they're increasing NMDA signaling at the glycinergic site of the receptor, but they don't make Clozapine better. And that's one of the most obvious clinical pieces of evidence that there is a glutamatergic mechanism. But how it's exactly doing it, people have postulated it's a partial agonist at the glycinergic site at NMDA. I don't think that's set in stone, but it's pretty clear that's part of the mechanism.
Not to get too esoteric, but there's a glycine transport reuptake blocker, and it's going for cognition. But Jonathan, do you think maybe they could consider using it for treatment resistance?
Well, the studies of drugs in that class tended to make negative symptoms better. They didn't have radical effects for positive symptoms. So I think, again, that may be only part of the story with Clozapine. As we know, there were a number of these glycine transporter inhibitors studied as monotherapy and adjunct therapy. The last one, of course, was bitopertin, and to not be too sarcastic, but Steve, it bit the dust.
But there's iclopertin, and iclopertin is rising from the ashes to try again.
Yeah, but I think it'll help. I think it'll help cognition, and I think that's the hope. Is that maybe it won't make other symptoms better, but we've maybe figured out for that mechanism, here's the best application for it.
Yeah, I was an investigator in one of the bitopertin studies. They were studying it for negative symptoms, and that's the eclopertin story. Originally, negative symptoms didn't work as well, but they found a signal for cognition, so they're switching gears there. But Jonathan, you taught me two other important things. Clozapine, and certainly its metabolite, has some muscarinic agonism. Can you tell me about that?
Well, now we're in the world of muscarinic receptor stimulation.
Yes.
If you all don't know what I'm talking about, please listen to more of these podcasts.
Yes.
Saturday Morning Live. The future of schizophrenia treatment has to do with muscarinic M1 or M4 receptor stimulation. What those do by different pathways is mediate presynaptic dopamine release. They reduce it, and they do it selectively in the area of the striatum associated with the positive symptoms of psychosis. It turns out that norclozapine has a lot of M1 agonism in particular, and in fact, it was actually studied by a pharmaceutical company as a standalone drug. The other name for norclozapine is N-desmethylclozapine. There may have been issues with the way the study was designed and the duration of the study, and it didn't separate from placebo, but many people think it was not for lack of antipsychotic efficacy because the animal models seemed to clearly indicate that it worked.
Yeah.
And we think it's certainly part and parcel of one of clozapine's mechanisms.
Yeah. Jonathan, I can attest to that. I did the norclozapine study, and it was a mess, the execution, let's just say. So I think the jury's out on that. And then you taught me something else. Clozapine is a TAR1 agonist.
Yeah, from animal studies, they have found that it has various properties on TAR1 in a way that other antipsychotics don't. Now, sadly, the pursuit of TAR1 agonists for the treatment of schizophrenia may have reached a bit of a standstill, we'll say that.
Right.
But again, the sum is greater than the individual parts.
Yeah.
Again, like lithium, and when you have a number of these mechanisms adding together, including the unknown way that it does modulate the ACC glutamate signal in resistant patients, we get its overall clinical phenotype, as we say, the clinical picture of its various activities, including resistant schizophrenia, schizophrenia with suicidality,
right,
people with aggression not mediated by psychosis, meaning impulsive aggression. It also works there. And it's probably any number of these properties adding up together to do what we think is special about clozapine.
So it has a direct anti-aggression type of property and an anti-suicidal property. The famous INTERCEPT study was done, of course, to show the decreased suicidality. Okay, well, so now we know that much, but yet it's still not being utilized. And I had a professor to this point who used to say dirty drugs are better, meaning multimodal drugs may be better because the brain's complicated and our illnesses are heterogeneous. But why isn't clozapine being used more?
Well, I think, to be honest, many people are fearful because they haven't been trained.
Right.
And sadly, even though they treat individuals living with schizophrenia, and they probably intellectually know that nothing else will work, but because they, quote, weren't trained on it, and sadly aren't also not motivated to learn, they simply deprive people of it. And it's unacceptable. It's below the standard of care.
Yeah.
And more I get contacted by families, and I hate to say it, plaintiffs' attorneys who say, hey, this loved one was deprived of clozapine for no good reason. And either the clinician outright lied to them, they said nothing will work, or they said, oh, clozapine is too dangerous, therefore it should never be used. Or they made some excuse and said, well, let's try something new, even though there's no evidence for any of the new drugs that they'll work in schizophrenia. It really is a black eye in the psychiatric profession. But I think the point that I tried to make when writing the clozapine handbook with Steve is that anyone can learn how to prescribe clozapine. It doesn't take a lot of effort. All it takes is some motivation and empathy for the patient who has an illness they never wanted and has a severe form of illness which doesn't respond to the other existing antipsychotics.
There's also some fear around the agranulocytosis or about difficulty in getting the REMs activated in the blood work.
I mean, that's part and parcel of the fear and the difficulties.
Mm-hmm.
We now recognize that, certainly in the United States, severe neutropenia does not cause mortality. I mean, it's exceedingly rare. Yes, you have to do monitoring, but we've come to appreciate that the monitoring burdens probably result in more deaths than they save. And why would I say that? Because, Steve, if you deprive people of clozapine, what's the likelihood that they're going to die from suicide?
High.
And what's the likelihood they would have otherwise died from neutropenia? minuscule.
Very low.
Minuscule.
Yeah.
There is
In fact, Jonathan, you can tell us what is the in the state hospitals the rare causes of death that we saw was almost never from neutropenia. What was it from?
It's usually from ileus. If clozapine is going to cause a problem, it was either ileus or people would get pneumonia because their sialuria was not adequately managed and they aspirated at night.
Yeah, that makes sense. So this is part of the issue of learning how to manage clozapine. These things are manageable. You can certainly monitor them and so on. Okay, so clearly it's not being utilized. Now, you guys work in the state hospital system in California, and I understand that there is certainly higher utilization there. And part of that may be you've got the structure to do it and people know how to use it. And part of it may be you see more treatment-resistant patients in that setting, so you have to use it.
Well, that wasn't always true, though, Andy.
I don't know.
When I started there 15 years ago, utilization was extremely low, but we made a concerted effort to educate people. And education really removes fear, and it also starts to change the culture. There would be clinicians who would almost, I would say, even brag, oh, I don't use clozapine, like it was some badge of honor rather than a badge of dishonor. And now that culture has largely changed. The person who doesn't prescribe clozapine is really looked down on by their peers. They're seen as somebody who's lazy, who's uncaring, who's unintelligent. And for the most part, we try to force them out, partly because they're not providing the standard of care. And also, to be honest, they're endangering the brain health of that patient. And for people who are aggressive, they're endangering the other patients and the staff as well.
I think that's definitely an issue. And you brought up something else important. There may be medical legal ramifications of denying a proven effective treatment to a subpopulation of patients who could benefit from it. So,
well, I think that's exactly it. It's below the standard of care. The idea that any clinician would actually proclaim, "Oh, I don't use clozapine."
Yeah.
I mean, you just can't imagine any other medical specialty.
Yeah.
Imagine going to somebody who treats breast cancer all the time, and she or he says, "Oh, I don't use the one drug which works particularly well for these resistant forms of breast cancer."
Yeah.
It just wouldn't exist. It would be completely unacceptable. I think it's unacceptable in our profession.
Yeah.
And I think more and more those who are out there working in areas with schizophrenia, if they have colleagues like that, I think it's okay to say, that's not okay. That's not acceptable.
Yeah. Well, what do you think about, at least if you don't do it yourself, knowing where to refer, having someone you can refer to do it? Would that be acceptable?
I think so, but I think you have to have the wherewithal to do that. But it's not acceptable to overestimate the risks of clozapine.
Yeah.
We know from every study that clozapine lowers mortality. Yes, there are some people who get medical complications, but we know that clozapine lowers mortality, and the longer people stay on it, the lower it exists, both from suicide-related causes as well as natural causes.
That's right.
I know you'd think, Steve, well, clozapine causes weight gain and metabolic problems. How do people have lower cardiovascular mortality on clozapine? But it happens because they're better. And now they go to their appointments and they take their meds and they get the care they weren't before when they had unremitting positive symptoms.
Yeah. I believe you're referring to, wasn't Tohonen did a study? There was a Scandinavian study showing exactly what you're saying.
Exactly. And when it comes from Finland, where they can track everybody, these conclusions are usually pretty sound.
Yeah.
We know exactly what's going on there.
Yes, the Fin 100 study, I believe they called it. And actually, compared to the other antipsychotics, there was lower mortality on long-term clozapine, which really knocked everybody's eyes out.
That's right.
And one of the biggest signals was people didn't kill themselves.
Yeah.
And so, if you don't treat with effective treatments, what is up to 15%, depends on the study, of people will kill themselves with schizophrenia. So it's one of the outcomes that really dictates that we should be treating.
Yeah, and I can imagine also less deaths related to aggression, because we know when people get aggressive or violent, they are at risk for getting killed themselves and accidents.
Yeah,
and
there's the unnatural causes of death. The big one is suicide, though. But look, even acts of aggression can bring harm to the person and to other people, results in their incarceration. It's not a good outcome for anyone.
So, Steve, is part of what we're doing today with this podcast to make people uncomfortable?
Well, in a way, but also motivated.
Okay.
I think the people who listen to this podcast are the cream. And so we hope that nobody feels scolded by this, but we want to have them feel empowered. And Jonathan's work in this book was nothing short of incredible.
I agree.
So the idea is, if you're afraid of clozapine, even though you hear that it's good, it's usually because you say, oh my God, if there were side effects, I wouldn't know how to manage them.
Right.
Well, there's a cookbook approach, so simple to actually manage every side effect that was written about in this book. So if you're in trouble, you've got this. But I like the idea of having a culture where this is used. I like, none of us are any good. If you're a brain surgeon, you never do an aneurysm except twice in 2 years, you're probably not any good at it. And so the idea is you got to do it a little more regularly and set up an infrastructure so you can actually manage the side effects as well as the lab and so forth. And then it's pretty good. And if not, then okay, refer, but then know someone who's got that infrastructure. And make sure that the patient is getting the clozapine.
Yeah.
But it's really, managing the side effects can be done. And, please, do that. Read the literature or even read our book, whatever.
Yeah.
But there's no real reason. That's why we've been so dedicated to trying to be positive about this and helpful with this.
Mm-hmm. Yeah, I agree. And, guys, I got to put in a plug for the Clozapine handbook. It really is tremendous. And Jonathan, while I don't know that you're going to get rich from this, I think you've done an incredible service. And as you and I have gone to various meetings, I've seen people come up to you and say how incredibly valuable and helpful it was to them. Speaking of Steve, you've brought up something I definitely want to get into, which is management of certain specific side effects. And let's start out with one that you've already mentioned, which is really troubling to patients, and that's sialorrhea. So, Jonathan, help us think through how to manage the sialorrhea.
Well, we like the norclozapine. Maybe it improves your cognition. Maybe it helps your positive symptoms.
Yeah, but
it
M1
makes you
agonism.
drool.
Yeah.
It makes you drool. But unfortunately, clozapine's a mixed bag because the parent compound is strongly anticholinergic in the gut.
Mm-hmm.
And we've recognized now that you cannot give systemically acting anticholinergics to treat sialorrhea as the first strategy, because you might make the drooling better, but you're going to give somebody an ileus.
Yeah.
And ileus can be fatal.
Right.
What we prefer now are locally acting anticholinergic strategies, such as atropine drops under the tongue, atropine 1%, or there's a nasal spray called ipratropium, but you're spraying it in the mouth, not in the nose, 0.06%. And I'll give people a little clinical tip. If you want that stuff to work better in the person's mouth, have them blot it dry with some paper towels before you put the drops or the spray in. It gets to the tissue more effectively.
Yeah.
If those don't work at maximum dosages, and the emphasis really is drying people up at night. Yes, it's a social problem if you drool during the day. It's not pleasant, but it's not going to kill you. If you aspirate at night, that can be very, very serious. Dry people up at night. It's not acceptable to tell somebody put a towel on their pillow. Yeah, the pillow is not going to get pneumonia. I'm just going to say, Steve, the pillow doesn't get pneumonia. After that, the preferred next strategy is actually Botox injections into the salivary glands. And if you've never heard this before, if you didn't know how Botox works, Botox is a permanent form of an anticholinergic strategy. It disables the cholinergic transmission machinery. And guess what? There are 2 forms of botulinum toxin which have FDA-approved indications for sialorrhea. This is not some weird strategy that Dr. Stahl cooked up in his laboratory. This is FDA-approved strategy for sialorrhea, and we've actually started a Botox clinic at the state hospitals to help with that.
Well, sialorrhea can be seen with other conditions as well, so it's not just for clozapine. You're right. They're approved for sialorrhea.
Yeah, and you can send people to either an ENT, to a neurologist, sometimes physical medicine, all do Botox injections into the salivary glands. And most importantly, these people are going to usually need maximum dosages because unlike somebody with cerebral palsy, they may drool, but they're not taking a drug every day which makes them drool. These people are, and you have to accept the fact that the first round of injection may not do as much as you hoped, but once you get to the highest dosages and give it a couple of rounds every 3 months, eventually you'll reduce their salivary flow to the extent that they may no longer even need the drops or the intraoral spray.
Okay, good to know. So atropine drops, ipratropium spray. I was medical director of a Clozapine clinic in the early 2000s. Jonathan, we used to use glycopyrrolate, but I don't know that that's effective, as effective.
It is effective, but it's the last resort. And it's the last resort because it's strongly anticholinergic.
Right.
If you get to that, and I understand you have to do what you need to do, make sure that you're managing the constipation really aggressively.
Right.
And the algorithm for constipation, since we're on that topic, is everyone gets Docosate as the price of admission. It's like a party favor. Oh, you're on Clozapine. Here's your little bag of favors, including Docosate. Next, you would add Miralax, max that out. Third, you would add a stimulant, which is usually bisacodyl. And then if that doesn't work, we bring out the new stuff, a secretagogue like linaclotide, which goes by the trade name Linzess. The point is, use those drugs. Do not ever give people psyllium, though. Psyllium sits around too much in people with really slow motility. And I don't know, what's the thing that happens, Steve? What do you call that?
Sludge?
People psyllium. What does it do to you?
Makes you silly?
Yeah. And what does it do to your colon?
Well, it stops it.
Yeah. Distension, I would think, or sludge or something.
Yeah. What happens is if the motility is so slow, the psyllium literally dries into a gel in the colon.
Not good.
And you've now created an even bigger problem than you had. It's not to be used for Clozapine-related constipation. For other human beings, for you, that's fine, but not for these patients.
Yeah. Another little pet peeve of mine is that I don't know that patients are adequately hydrated. And if you're not hydrated, you're also going to get a hard stool. So hydration is certainly important, but that leads me to another issue with Clozapine, of course, and that's the over-drinking, the water intoxication syndrome.
The
polydipsia.
We think psychogenic polydipsia is usually a thing you only see in the state hospital type patients. And we think it is a manifestation of treatment resistance. And how do we know that? Because back in the day, they used to have these people who didn't respond to dopamine blockade. And shockingly, you put them on Clozapine and it gets better. It's another group of people where we also see a unique value for Clozapine. But if you have folks who are drinking the bath water, drinking the toilet water, they're really ill, they need Clozapine, and they really are the poster child for somebody who needs Clozapine.
Well, it's interesting. A misconception is that Clozapine causes the polydipsia, and you're saying, no, that's not the case at all.
It's the exact opposite. It's the exact opposite.
I've heard that, though. Okay, great. Are there other kinds of things we have to watch for or try to manage when we're using Clozapine?
Well, one thing I'll just say, which we alluded to in terms of the impediments, you're obligated legally to do the monitoring. But I can tell you right now, there's a group of people out there who are very upset with what's happened with the REMS system.
Yes.
The vendors changed a few years ago. We lost all of the old monitoring data. It just disappeared.
Oh, my goodness.
It became an enormous mess during the pandemic. And Clozapine was approved 35 years ago. It was approved on September 26, 1989. And maybe at that time, the FDA's position was the psychiatric profession was unfamiliar with what neutropenia is. It was incapable of monitoring this drug. I don't think anyone believes that to be true now. We now see that the REMS causes more deaths than it prevents. And there's people out there, literally a group called the Angry Moms. And for those of you who are interested in this, look up the Angry Moms, maybe the other search term Clozapine. And
is that like the Angry Birds?
Yeah, very much so. This is like the Mothers Against Drunk Driving. In this case, it's the Mothers Against Clozapine REMS. And their job is to get the REMS taken away from the need to prescribe Clozapine. Look, there's people out there who give chemotherapy all the time. Toxic stuff. Yeah, sometimes people die from it. There's no REMS for that. This is a drug which has been out for a third of a century. Everybody knows the monitoring you need to do. There's no reason to have a REMS tied to that. If the clinician doesn't do the appropriate monitoring, well, that's on them.
Right.
I have a feeling in the United States, given our, litigious nature, people will do the appropriate monitoring.
Right.
But the need for REMS is long ago past. It's now become an impediment to care. And groups such as the Angry Moms, really, it's their crusade to have Clozapine more widely accessible. You wonder why people can't use it. Well, one of the impediments is patients don't want the weekly blood draws.
Right.
It's a pain in the neck. It's a pain in the neck to get the results to the pharmacy. There's a dispensing delay. People run out of drug. It really is just an unfortunate
And pop
situation.
quiz, what's the worst drug in psychiatry to stop precipitously for the treatment of psychosis, it's clozapine.
It would have to be clozapine.
So, when you do stop it, you have to taper it over very long periods of time. So you run out of REMS,
That's right.
Pharmacy won't fill it,
Yep.
can't get this prescription, and you just have mandatory involuntary discontinuation abruptly.
Abruptly, a big-time cholinergic rebound. So not only do these people become floridly psychotic, you've exacerbated that even further with the delirium from cholinergic rebound. I want to say it's the best of both worlds, but it's the worst of both worlds. It's really a nightmare for the patient.
Let's separate the REMS out from the blood draws. So you're saying that we should still monitor blood work periodically, but maybe not as rigidly as with the REMS.
I think it needs to be done. We know the period of risk is highest in the first 6 months. Right. It drops off dramatically well after month 12. And the value for the isolated cases after month 12 is really debatable. Jose Rubio did an analysis recently. Look, there's a small rate among other antipsychotics too. It's not zero, but the differences become very, very small. And it's hard to prove, certainly as you get past month 12, that monitoring really does anything.
And also there's now finger sticks.
Yeah, I was going to ask about that too, Jonathan. I know you're involved with some of that, with some easier ways to get the blood.
Yeah, there's a machine out there made by a company up in Mountain View, California. The company's called Stahl. It is a machine which will give you your neutrophil count and other CBC parameters with a finger stick. You get the result in 6 minutes.
Wow.
And it certainly removes a big impediment to getting the ANC result because it doesn't hurt as much and you get it right away. Why is that helpful? Well, in the state hospital, Steve and other people have been instrumental in getting these devices on the units. You think, well, we have phlebotomy. What's the big deal? We have very sick patients. They wake up in a bad mood and they don't want their blood drawn. Look, at some point, the pharmacy won't dispense the drug. So what? You say, hey, Mr. Jones, go have your breakfast. Don't worry about it. Afterwards, come by the nurse's station and we'll do a finger stick. And there you go. And now we get somebody who's really ill to stick with their clozapine. Out in the community, many community mental health centers have purchased these machines. They use them both in the office and they can take them out in the field as well for folks who aren't mobile, who never would have been able to get clozapine. Now you have somebody who can do the monitoring to them. You can get the pharmacy to deliver the meds to them. There's some very large group homes or what we call boarding cares here in San Diego who themselves have purchased these machines. They're thinking, why do I want to drag 50 people to the lab every week or every month when I could just line them all up on, first Monday in the month and everyone gets their finger stick and everyone's happy. It just really removes a huge barrier to care.
So if there was not a REMS, Jonathan, what would you recommend as far as frequency of blood draws? Would you still do weekly for the first 6 months and then every other week and then at 12 months stop? Or would you recommend something different?
Yeah, I think the data most strongly support during the first 6 months. I think it's not unreasonable to continue that out a little bit. It's harder to justify after a year. And that'll be, if it ever comes to pass, it'll be up to the clinician. If they feel more comfortable doing it, that's fine. If it now becomes accepted that this is not mandatory, now the standard of care has shifted. And that's critical. If the standard of care has now shifted, then it's no longer inappropriate to say, I don't feel like there's a benefit from monitoring you after month 12. I think we as a field would have to come to a consensus, though, so folks don't feel like they're being left out on a limb if something happens. Again, there are rare cases that will happen after month 12. We had one at the state hospital. The person didn't expire. They were noted to have a low neutrophil count on some random tests, and then they were sent to the clean room for a little bit, and they were fine. I think that it's important, though, if the REMS is ever removed, that we have a consensus statement. And I suspect there's a lot of people like John Kane and Christophe Clarel and Jose Rubio and Jose de Leon who would all come together and say, this is what seems reasonable.
Well, I would hope you'd be part of that, too.
Too much concentration on this over-monitoring by REMS means silly, interesting, easy things like watching concomitant anticholinergics and understanding what drugs are very anticholinergic but not classified as that.
Right.
And what Jonathan and I have said is that what kills you is ileus. Right. Most psychiatrists don't put their hands on people's bellies very often, And so, the idea is you have to stay ahead of the constipation and not chase it. And, the ileus is potentially toxic. And how many people, Jonathan, have we seen that are on chlorpromazine and clozapine at the same time?
Sure.
And maybe two other and we love it. Cogentin
absolutely.
Daily.
Yes.
Therazine PRN
Yep.
and clozapine every day. Now, that is a burden of anticholinergic that is just ridiculous.
Right.
And so paying attention to that is so much more of an effect size to help prevent death, if you will, is certainly the disability. And why it tends to get neglected.
The FDA actually issued a memo in January of 2020, and ironically, it was literally the week after we had a death at one of our state hospitals. That patient was, Steve, on clozapine, chlorpromazine, and benztropine.
Oh, goodness.
Absolutely unavoidable, absolutely preventable. All I'll say to the audience out there is, if you have somebody on an anticholinergic antipsychotic, I suspect there's not a lot of chlorpromazine, but it should never be used with clozapine. But let's say you have somebody on olanzapine or maybe high-dose quetiapine, and you're transitioning them to clozapine, you need to taper off the anticholinergic agent as clozapine is started. And that is true also for the benztropine and for the diphenhydramine.
Right.
As you add clozapine, those agents should be tapered off. Clozapine is anticholinergic enough. If you're a non-smoker, 50 milligrams of clozapine is as anticholinergic as 1 milligram of benztropine. If you're worried about they need the anticholinergic because they got really Parkinsonian on their haloperidol decanoate, fine. Your new anticholinergic now is clozapine.
Right. Well, clozapine has an incredibly low risk for, Parkinsonism anyway, and movement disorder, as we know. Steve, I'm glad you brought that up. I mean, Jonathan, you and I certainly are on a crusade with our friend Les Citrome to try to minimize anticholinergic burden. And I really appreciate what you're bringing up because I think a lot of people just don't realize, and Steve, you said this, there are some other drugs that we don't think of as anticholinergic, but these patients end up on so many different medicines, including antihypertensives and so on, to treat other things that when you add it up, a lot of drugs with a little anticholinergic effect is a problem, but definitely we should avoid the obvious ones. Benztropine is like a benzodiazepine. Once people start it, they just never stop it. People just perpetuate its use. And so like you said, Jonathan, maybe they were on another antipsychotic and that was stopped, but they just continue the benztropine or diphenhydramine or whatever.
Even if they needed it, they were Parkinsonian and the person for some reason didn't understand that amantadine has been around for 4 decades. Yep. Oh, I had no idea.
Yep.
There's another way to treat Parkinsonism, people. It's not benztropine. It's either dose reduction or amantadine. I'm just saying that.
Yes.
That being said, fine. They're Parkinsonian on their D2 antagonist. You couldn't get rid of the benztropine. Fine. But as you add the clozapine, just taper off the benztropine and the ratio roughly of 1 milligram benztropine for every 50 of clozapine. And that'll take care of your drug-induced Parkinsonism.
Well, that's an extremely helpful algorithm, if you will. Can I just get back, though, to the monitoring for a second? So, Jonathan, would you still recommend weekly blood draws for the first 6 months? Or are you saying we might be able to space that out a little in the first 6 months?
That's the period of biggest risk. And I think that seems reasonable. Yes, it's a burden, but it's kind of fixed in stone. I would think if we even get to the point where REMS is no longer in effect, I would say this is a period of biggest risk. That makes perfect sense. Tapering off after the second 6 months. Yep. No one is going to implement this until we get FDA approval because there'll be a liability issue. I'm just saying it right now.
Right.
But the hope is that if we can get REMS out of the picture, then maybe this will become something which we can talk about more realistically.
So we have that group of moms advocating, but what other kind of practical strategies can we use to get rid of the REMS? Is there some mechanism to do that?
Well, the FDA has solicited comment. You can go to the website and look in clozapine and see where you may also have to have their input. I think they're going to have a meeting in this fall as well. The more voices that they hear, the better. The sad part is, unfortunately, the people who manufacture clozapine somehow think that having REMS indemnifies them in some weird way.
Yeah, I see.
Everyone knows what the risk is. Again, this is not a new drug. It was approved 35 years ago. If you don't do the appropriate monitoring, then you're liable as a clinician, just like it is for a chemotherapy drug or other drugs with known toxicities.
Yes.
This is not a brand new agent like it was in 1989.
Yeah, well said. All right, I want to shift gears and talk about something else, and that's thinking about ways to manage maybe the neutropenia. So one of the things that we used to do, again, when I was working at the Clozapine clinic, was we would use lithium. And certainly, Jonathan, you know a little bit about lithium too. And we were told that it was degranulating the neutrophils. But you've told me that there may be more to the story than that. So is it reasonable to add lithium, and what's going on when you do?
So number one, the best way to have neutropenia or avoid severe neutropenia, which is the term we use now, is to not be aggressive with the titration. I think we've come to appreciate that the more aggressive titrations tend to increase the risk. There's not a great value in doing that, because if you shoot yourself in the foot and give the person severe neutropenia, I don't know, Steve, what else are you going to give them, right? You have resistant schizophrenia? What else are you going to give them?
Right.
Maybe ECT.
ECT, maybe.
Yeah, ECT.
Yeah, you don't want to burn the only useful mechanism for resistant schizophrenia. Secondly, there's another drug which is on its way out. We've already talked about how anticholinergics are probably drugs of the past, but I think Steve knows what anticonvulsant I'm talking about, which is probably on its way out because of its reproductive harms. You want to just tell them what I'm saying, Steve?
Well, there's a drug that actually changes your gene expressions by changing an enzyme that has to do with genes turning on and off. It's called histone deacetylase. And valproic acid is a histone deacetylase inhibitor. I believe, actually, Jonathan, nobody talks about it, isn't carbamazepine also? And so the issue is that it can cause birth defects. And it's not just women whose eggs get changed. It's men whose sperm gets changed. And so it's probably close to being on its way out. In this case, the U.S. is a follower. The UK and Europe are already in the process of essentially banning it under the age of 55.
Yeah.
I want to encourage everyone, if you can hear the name that I'm saying, there's a paper which just came out in JAMA Network Open just within the last couple of months. The first author is Smolinski, but the title is Prenatal Exposure to Valproic Acid Across Various Indications in the U.S. It should be 0. Because women who take valproate during pregnancy, the kid has a 30 to 40% rate of an intellectual disability. 30 to 40%.
Wait a minute. Say that again.
Fetal valproate syndrome occurs among 30 to 40% of babies who had first trimester in utero exposure.
Oh my!
It's been banned in Western Europe for many years.
Yeah.
How the rates are not 0 in the U.S. just boggles my mind.
Yeah.
The point being is it should no longer be used for women of reproductive potential. And as Steve said, even a man taking it, his child has 1.5 times increased risk of a neurodevelopmental disorder.
Wow.
But the reason we're going off on this rant is that, guess what? When you use valproate at high serum levels, it also causes neutropenia.
Right.
And it doubles the risk for neutropenia. If somebody needs mood stabilization, they should use my favorite mood stabilizer, which is, as Dr. Cutler said, is lithium.
Yes.
And that's fine. That's great. You just swap them over. For one thing, you're avoiding perhaps a significant, medical legal problem, to say the least, by having somebody on valproate who doesn't have a permanent form of birth control, if they're a woman, or for a man who hasn't been appropriately consented, but also minimizing the risk of neutropenia. So those are the two best strategies. Right. Now, there are some people who live close to the line. The line, let's say, if you don't have benign ethnic neutropenia, is a neutrophil count of 1,500. Let's say you're not on valproate, but your neutrophil count at its low is always around 1,600. And you don't want to have to worry that if they drop below the threshold, you're going to have to monitor more frequently, which is a pain in the neck. What you were taught, Andy, when I was taught, wasn't exactly right. We were taught that, I think the term was demargination.
Demargination. Sorry, I realized that. Not degranulation. Demargination. Coming off of the walls of the blood vessels.
These neutrophils were in a hiding. Now they come out. That's not what happens. You know what? You know what lithium does? It causes you to make more granulocyte colony stimulating factor. You make more stimulating factor. You make more cells.
That's a good
thing. That's exactly what it does. It's like giving a weak version of Neupogen, and it will boost your neutrophil counts. If you have somebody for whom you're having trouble getting them to the threshold they need, and they're not on valproate, and you've made sure they don't have benign ethnic neutropenia, lithium now becomes your friend, and you can increase neutrophil levels quite significantly, and hopefully allows you to keep somebody on clozapine, or if you haven't been able to start them, now to start them.
Yeah. Well, wait a minute. If you have a benign ethnic neutropenia, you can't take clozapine because it's just too complicated to figure out how to monitor them, right?
Oh, yeah. Not exactly true, Steve.
Oh.
Yeah. Guess what? Well, it's a couple of things. People with BEN usually come from certain parts of the world, sub-Saharan Africa, Middle East, even some parts of Asia. We have a different lower ANC threshold for these people. And if you're suspicious that somebody has BEN, all you have to do is order the simple blood test. It's called a red blood cell antigen, but for the Duffy antigen. You have a number of antigens on your red blood cells. Don't order the whole panel. I don't care about the other ones. There's a lot of them. The hematologists know this. But we're not doing a type and cross because you're going to have surgery. All we want to know is, do you have lack of expression of the Duffy antigen? If you have BEN, you will be what's called A-, B-, or sometimes the lab report will say null. If people have BEN, then, you have a different threshold for starting clozapine or for holding it. And guess what, Steve, which I think you know, people with BEN actually have lower risk for severe neutropenia than the rest of the world. Just as easy to start them, but you have to know what the test is to diagnose BEN. And now you all know.
That is counterintuitive and very interesting.
Well, this is one of the things people talk about. Being advocates for different racial groups, and this is one gap in education that can be filled. That's in other words, about diversity and equity, etc. So it's shame on us for not doing that. We hear a lot about that, but the real science does exist, that there are differences between ethnic groups, and disadvantaged ethnic groups tend to not be educated because actually, you'll just have to actually educate people about white males, about what happens to them when they take drugs, right? Well, unfortunately, that's too much of what happens. But the nice niche that Jonathan just mentioned is an important one for listeners to do, because you will have people from these parts of the world, and there's really no excuse for not being able to treat them equally. Right.
So just getting back to lithium, though, lithium is certainly very reasonable to help in these situations, and it's got the double benefit of being neuroprotective, and we know schizophrenia is probably to some degree a neurodegenerative illness, so it's certainly reasonable. The other one, guys, of course, we need to probably avoid is carbamazepine, and even oxcarb probably still has some degree of risk. People think oxcarb somehow is a kinder, gentler, safer, but not always.
Yeah, no, I think we could think of it as an ineffective mood stabilizer, which causes more neutropenia, more hyponatremia than carbamazepine.
Yeah, that's right.
And with less efficacy. So you get the best of both worlds. Lots of hyponatremia, less efficacy, and some enzyme induction.
That's right.
I think everyone should be on it. And I'm being very sarcastic when I say.
Yeah. So the carbamazepine family, of course, we should probably try to avoid too. So like you said, for mood stabilization, lithium would make sense, possibly lamotrigine. There was some Israeli data that adding lamotrigine to clozapine improved the antipsychotic effect, but that hasn't been largely reproduced. Steve, you brought up something else that I want to ask. It certainly makes me wonder. We know that lower socioeconomic classes and certain minority groups get worse care in general. Is it possible that they're getting less access to clozapine too? Do we have any information on that?
I don't know the studies on this, but I believe that is so. I mean, the reality is that there's just less treatment in general for poor people. And this is a problem of getting access to care. And so, Jonathan, you actually know of any data that show that Black Americans, for example, get less clozapine, or poor Americans get less clozapine?
It tends to devolve more so on, I hate to say it, your outward phenotype. If people are African American, but the association really is also not only with the socioeconomic and deprivation of people who are in socioeconomic strata of adequate care of many types, but also because of their higher rates of benign ethnic neutropenia. And sadly, many people are still not well informed about this. They'll tell somebody, oh, your neutrophil count's too low. Even though had they done the appropriate test, they would realize, hey, guess what? This person has BEN and they qualify clozapine because the starting neutrophil count just has to be above 1,000 instead of 1,500.
Got it. Well, that's certainly helpful information, guys. Jonathan, I'm assuming that you have some guidance on starting clozapine from scratch, if you will. And do you also have some guidance in the handbook on how to switch? That's a question we get asked all the time as well.
Yes. Yeah, so a couple of things. In terms of starting it, Jose de Leon was part of a big group which wrote a paper recently saying, look, you have to take into account people's ancestry or their heritage, because there are biological variations in how folks metabolize clozapine. And if you titrate clozapine too aggressively in somebody who, by virtue of their background, might be a slow metabolizer or poor metabolizer, you're going to run into problems. You have to take into account someone's heritage. You have to take into account their gender, because men tend to metabolize clozapine more quickly than women. And then lastly, you have to take into account whether they are a cigarette smoker.
Yes.
And I'm being very specific. Cigarette, you have to burn the leaf. If you burn the leaf, you generate aryl hydrocarbons, which induce the expression of the 1A2 enzyme. But if you're just vaping, you're not burning anything. You're just heating a nicotine solution, and you won't induce your 1A2. But smoking, big variable. Your gender, big variable. Your heritage, enormous variable. These all have to be taken into account. And I think the point is, if we titrate people too rapidly, we run into problems, some of which may be very serious, not only severe neutropenia, but also myocarditis. And then maybe you've lost the only mechanism that might make these people better. It's in the handbook. You can look up Jose de Leon's paper from a couple of years ago, and it's something that you can use as a reference. And they have a number of tables for different titrations depending upon the various parameters as suggestions. In the end, though, once you get to a nice round number of clozapine, like 100 milligrams at bedtime or 200, get a level, because the level will tell you where you're at, and that'll be the final answer about how they really metabolize clozapine. And I think that's probably the most important concept to take home from this. The other one is transitioning from other drugs. I often will leave people on the other antipsychotic if it's not anticholinergic. They come to me on paliperidone palmitate or the new risperidone sub-Q, haloperidol for the phenosine decanoate. I don't care. They're not anticholinergic. They're going to play perfectly well with clozapine. And even aripiprazole plays well with clozapine. Aripiprazole as a partial agonist doesn't play well with other antipsychotics because it's going to knock them off the D2 receptor. I could care less. As we've talked about with Steve, whatever magic clozapine has nothing to do with binding to the D2 receptor. I don't care if aripiprazole wins that battle. Leave those alone. The ones you want to get people off of are olanzapine, quetiapine, I guess the few people out there on chlorpromazine, and also the concomitant anticholinergics. Those need to be tapered off as clozapine is started, with the idea is that once you get to a clozapine dose, which you think might get you into a ballpark level of response, which is going to be at the bare minimum 350 nanogram per ml as a 12-hour level, they should be largely off the anticholinergic agents. You just don't want to give people an ileus.
Yeah, and you mentioned getting
and then
the
what
level.
about stopping it? The idea is 4 weeks, 4 weeks, 4 weeks is generally what we would say, both to stop the precipitous anticholinergic rebound and also to stop a psychotic rebound. So don't cold turkey clozapine.
Yeah, excellent.
There's very rare reasons why you'd ever have to stop it. Severe neutropenia is really the primary one. During the days of COVID, people sometimes would have abrupt changes and increases in their clozapine level because of the acute infection. Doesn't mean you have to stop the clozapine. If you want to reduce it by 50%, that's fine. But don't just, as Steve said, cold turkey it, because you're going to make this person psychotic and delirious. On top of their COVID, it's probably not a recipe for success.
Yeah. Before we end, Jonathan, you mentioned something else real quickly. What can you say about the myocarditis? Is this something that is common or that we can monitor for? Just a couple quick words about that before we end.
Yeah, I think more and more we're recognizing it's something that could be monitored for. Slowing the titration, we think, helps. Not having people on valproate, at least in some analysis, may reduce the risk, meaning valproate may increase the risk. Slower titration probably helps. What labs should you look at? The two labs which have inconsistent analyses appear to be associated with the myocarditis are elevations of troponin, or in some cases, in more than 2 times upper limit of normal, or severe elevations of CRP, meaning more than 100. We never see levels of 100. If you go for your
Yeah.
cardiovascular risk assessment, they're talking about numbers in the range of 1 to 3. Like,
Right.
oh, your number's above 3. Okay,
Yeah.
we're talking very high levels. But
Okay.
people do now monitor those weekly for the first 6 weeks. That is the period of risk. And if you see a troponin, which is 2 times the upper limit of normal or greater, well, that probably means they got it. If the CRP is more than 100, they also got it too. And the reason we throw in CRP is there was a small subgroup of people where the troponin didn't quite meet the threshold, but they had this really high CRP. But it's not forever. The period of risk is the first 6 weeks. And that's the whole point. If you want to do it for 6 weeks, that's fine. This is exactly.
Careful with the titration. How common is it? Not common, I would hope.
Yeah, the rate is probably roughly around 1%, maybe a little bit less. In some analyses, maybe slightly higher. Again, part of it may relate to practices, people being titrated more aggressively, things that we maybe used to do in the past, which we think is maybe not the best way to go. Not common, just like severe neutropenia, but could be a serious outcome if it's not recognized.
All right. Well, Jonathan, I really want to thank you for joining us. This was incredibly helpful. I think we've only whetted people's appetite, and hopefully we've got them, if not uncomfortable, but opened their eyes a little, got them to want to know more. And I can't recommend highly enough the Clozapine Handbook. If you're someone who is wanting to implement Clozapine into your practice, you're doing it, but you're not sure, this book really is a tremendous resource. So, Jonathan and Steve, thank you both for writing this, for doing this service to us. And I want to thank you, the audience, for listening, and of course for more episodes of the Psychopharmacology series. We've now been doing this for a few years, and there's some terrific episodes. Wherever you get podcasts, you can find them. You can either search under Psychopharmacology, you can search Stahl or my name, and we have a channel that is NEI Psychopharm. And certainly you can go to our website for more of these podcasts and other educational offerings, and our website is NEIglobal.com. Thank you so much. Until next time.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.